Hello and welcome everyone. Today we will be discussing the management of major hemorrhage in ICU. So what is the incidence of major bleeding in the ICU? It is reported to be 5% to over 50% with significant morbidity and mortality. Now why is there so much variation? Why is 5% to over 50%? The main reason is the assessing the rates. There is a lot of variability in the definition of the criteria used to define a major bleeding in the ICU. This is the main reason why we have so large variation. Even the surgical ICUs tend to have more bleeding compared to medical ICUs. So the definition of major bleeding according to the International Society of Thrombosis and Hemostasis is a symptomatic bleed in a critical area or organ or bleeding causing a fall in hemoglobin of 2 gram per deciliter or leading to transfusion of more than 2 units of whole blood or PRBC. So there are three things. Either it is into a critical area, or it has resulted in a hemoglobin drop of more than 2, or I have required more than 2 transfusions. If any of these is present, it is considered as a major bleeding. Now, altered hemostasis and coagulopathy potentially exacerbated by comorbidities and underlying disease is the most important reason of ICU bleed. Rapid and definitive strategies are required to mitigate bleeding with the administration of blood components and a balance to avoid physiological alterations. Now, understanding pathophysiology in the specific disease states and effective individualized managements is critical in the optimal outcome in case of bleeding in the ICU. So first is the pathophysiology. What are the reasons and what are the conditions which predispose a patient to increased bleeding? The first and the most common one is the trauma. Trauma-related bleeding risk, that is higher injury severity or hypovolemic shock, significantly increase the risk of severe bleeding due to a condition which is called as trauma-induced coagulopathy. The central features of this are increased fibrinolysis, activation of protein C pathway, platelet dysfunction and consumption of clotting factors, endothelial activation and increased microvascular permeability and loss of endothelial glycocalyx, hyperfibrinolysis in the trauma, which is common after severe injury, which is characterized by increased plasmin activity due to elevated tissue plasminogen activator levels released by the activated endothelial cells. There is a more detailed video on the management and the pathophysiology of trauma-induced coagulopathy. If you want, you can see that video. Now, fibrinogen levels in the trauma can be critically low in the early stage due to trauma-related hemorrhage and increased breakdown, that is fibrinolysis, consumption, dilutional effect of the resuscitation fluids. The activated protein C, what is its role? The high level of activated protein C contributes to the early hypocoagulable state by inhibiting factor 5A and 8A and binding to plasminogen activator inhibitor 1, thus promoting fibrinolysis. Characterized by reduced aggregation, the platelet exhaustion occurs. The mechanisms include defective calcium mobilization, GP4 alterations, and damage to the releasing histones. Now, endothelial activation and glycocalyx disruption is caused by direct injury, shock, catecholamine release, hypoxia, changes in the blood rheology, leading to loss of protective endothelial glycocalyx. The next important condition is the postpartum hemorrhage. Unlike trauma-induced coagulopathy, the coagulopathy associated with PPH is not been extensively studied. Most PPH cases do not involve coagulopathy, but large volume hemorrhages can lead to dilutional and consumption coagulopathy. A less common but significant condition similar to TIC, the obstetric coagulopathy, is characterized by massive fibrinolysis occurring in approximately 1.06 per thousand pregnancies. It is a complex multifactorial coagulopathy seen less frequently than the trauma case. Pregnancy induces significant increase in the circulating fibrinogen levels. A fibrinogen level below 2 at the onset of PPH is strongly associated with the increased need of large volume transfusions. Now, the clinical conditions leading to acute obstetric coagulopathy. Amniotic fluid embolism and placental abruption can trigger the type of coagulopathy, both of which result in profound and rapid decrease in fibrinogen levels and overt fibrinolysis. Unlike in trauma-induced coagulopathy, dysfibrinogen that is abnormal fibrinogen function, is detected in obstetric patients, highlighting the importance of measuring and adequately placing fibrinogen in the management of PPH. The next condition is chronic liver disease. Now, the incidence is around 12.5% in patients with CLD managed in the ICU who develop significant bleed. 3/4 of the bleeding events in the CLD are GI, with over 90% due to portal hypertension. Patients with CLD exhibiting coagulation factor deficiency, platelet dysfunction, and hyperfibrinolysis, yet there are compensatory pro-hemostatic changes that mitigate this hypocoagulable state. Routine lab tests that is commonly showing thrombocytopenia, prolongation of the PT, but patients with compensated CLD do not necessarily have an increased risk of bleeding or thrombosis. Patients with CLD have limited resilience to additional illness or injury, making them susceptible to both bleeding and thrombosis upon decompensation, encountering an insult like infection. The most common acute bleed in CLD is varicocele, where the management focuses on the clinical treatment to reduce portal pressures and large volume resuscitation and correction coagulopathic defects. The next is DIC, that is disseminated intravascular coagulation. It is an acquired syndrome secondary to conditions like sepsis, malignancy, trauma, and obstetric complications. It is characterized by a systemic coagulation activation leading to intravascular fibrin-rich thrombi and organ dysfunction. It results in a prothrombotic bleeding or mixed phenotype due to the widespread thrombosis and consumption coagulopathy. Decreased levels of antithrombin and protein C due to consumption and extravasation contribute to the complexity of the pathophysiology. Along with the depletion of the platelet and coagulation factor, elevated fibrin degradation products and systemic inflammation impair platelet function and fibrin cross-linking, exacerbating the risk for bleeding as well. Depending on the DIC phenotype and the underlying disease, with a focus on addressing the primary condition and managing coagulopathy signs, the treatment is to be given. The next is uremia. Associated with CRF, uremic bleeding is a recognized complication of chronic renal failure characterized by significant platelet dysfunction. The platelet dysfunction is believed to involve multiple factors including von Willebrand factor dysfunction, impaired platelet binding and tethering, alteration in the platelet signaling pathways. The key factors in the platelet dysfunction are decreased thromboxane production and increased prostacyclin I2, elevated cyclin AMP or GMP levels, accumulation of uremic toxins, alteration in the platelet granules affecting normal platelet aggregation. And finally, the management challenges is transfusing platelet may not necessarily correct the platelet dysfunction due to these complex factors that are taken into account. The next is acquired coagulopathy secondary to the anticoagulation, that is the patient who are commonly in the ICU. So critical ill patients often require anticoagulation as the part of a thromboprophylaxis or disease-related therapeutic anticoagulation, increasing their risk of a bleeding, which can be a primary reason for ICU admission occurring during their stay. A multicentric retrospective study in France found that ICU admission from severe extracranial bleeding related to anticoagulation rose from 3.2% to 5.8 per thousand in 2018, with the ICU mortality rate of 27%. In the study cohort, vitamin K antagonists were used for 54% of the patient, heparin in 25%, and DOACs in the 7% prior to hospitalization. The complication of anticoagulation therapy, that is extracranial bleeding, is a significant impact on the mortality and organ failure. Therapeutic management is often hampered by inadequate lab monitoring, limited clinical management experience, and absence of reversal agent for most of the anticoagulants. Enhancements in education, development of an anticoagulation reversal agent protocol, and more accessible lab hemostasis measurement for patients with anticoagulation are critical in better management and improving the outcomes in this patient. So if a patient comes with bleeding, how do I diagnose and how do I evaluate that patient? Early recognition, early identification of bleeding is crucial to prevent the onset of shock and organ failure in the ICU. So you must keep a track on the trends of the patient, trend in terms of tachycardia, hypotension, the blood hemoglobin levels, clinical signs of hypovolemia, that is new worsening tachycardia, tachypnea, narrowing pulse pressure indicating low blood volume should be kept in mind. A sudden increase in lactate levels, base deficit can serve as trigger of initiating a treatment. So you must be very, very critical in analyzing these things, and measuring the trends is very, very important. Diagnosis may be complicated by the presence of other hemodynamic disturbances like SIRS, septic shock, or use of inotropes and vasopressors. A decrease in platelet count or prolongation of the PT and APTT may indicate developing coagulopathy. While decrease in hemoglobin is expected, it may not fall acutely due to the severity of the bleeding and delayed compensatory mechanisms. High suspicion of index is required. It is crucial to maintain a high level of suspicion in case of hemodynamic decompensation with normal blood counts and coagulation parameters. Understanding the severity and underlying etiology of coagulopathy is vital for appropriate management and individualized care. Main diagnostic tests include the APTT, PT, fibrinogen levels, and presence of fibrin degradation product like D-dimer. And increased D-dimer over 2 days is a practical marker for predicting acute fibrinolytic activity. Now, the other tests like the point of care viscoelastic tests like TEG or ROTEM can offer a faster and more complete picture of the coagulopathy, aiding in directional intervention and assessing their effectiveness. The TEG or ROTEM have shown benefits in managing hemorrhage in setting of cardiac surgery, obstetrics, and liver disease, among other cases. These tests can help diagnose hyperfibrinolysis through a very low sensitivity. Parameters like maximum clot firmness and clot amplitude at 10 and 15 minutes can provide indirect evidence. The ELT, that is euglobin lysis time, is a standard reference for diagnosing hyperfibrinolysis, but is rarely performed due to challenges in the assay method. Many critically ill patients exhibit coagulation abnormalities as a function of their underlying disease process, which often normalizes with the management of the underlying condition. In absence of acute or impending bleeding, these abnormalities may not require correction. So to summarize, these are the various bleeding conditions that we have seen in the pathophysiology. This is the related pathophysiology of the disease process, and in considering the specific conditions, you can do the lab test as summarized in this table. So how to manage this, the major hemorrhagic protocols? So the objective of the team is to provide standardized evidence-based care to critically ill patients with major bleeding and associated coagulopathy, requiring coordination among multiple hospital teams. Though not universally adopted, standardized massive hemorrhagic protocols reduce complexity in management of major hemorrhages and have been shown to improve patient survival and minimize complications related to massive transfusions, typically defined as transfusion of at least 10 RBC units within 24 hours. Initial development of trauma patients, where these protocols have been used in clinical settings beyond trauma. Now, many of these protocol components are based on the biased observational studies such as high plasma to PRBC ratio, which initially showed a significant mortality reduction, but later studies found no mortality effect after a time-dependent analysis. Transfusing plasma and platelet is crucial once the large volume of RBC has been transfused to prevent or correct the coagulopathy, as RBC transfusion alone does not support the coagulopathy and may contribute to the dilutional coagulopathy. D negative females of childbearing potential typically receiving O negative PRBC to prevent alloimmunization, Rh positive related hemolytic disease of the fetus and the newborn. So in these cases, you need to avoid giving positive blood. However, the immediate risk of morbidity and mortality from traumatic hemorrhage is prioritized over the potential risk of alloimmunization. But then, even though we are looking for the negative blood, we obviously don't allow the patient to die for the need of the negative blood. If the positive blood is present, it is always given for the life save. Now, the product inclusion and changes in the protocol: the use of group A plasma due to limited availability of AB plasma, adoption of group O low titer whole blood for immediate management of traumatic hemorrhage, the use of cold stored platelets which are already partially activated and cleared within 24 hours, potentially offering more effective support in hemorrhagic setting through clinical trials are ongoing. The protocols continue to evolve with new data and clinical practice, including the potential broadening use of group A plasma and cold storage platelets to optimize care of patients with major bleeding across various settings, not just restricting ourselves to the trauma management. Now, the implementation and structure of this protocol. The aim is to provide time to physician to control the bleeding, minimize the crystalloid use, and understand the coagulopathy, facilitating the development of a personalized treatment plan. Now, the protocol-based structure, essential to deliver the blood products and lab tests algorithm, including the use of medications like tranexamic acid, tools to blood warmers to preventing hypothermia. Effective implementation relies on teamwork, situational awareness, clear communication, well-defined task and decision-making process. MHPs are ideally developed as consensual protocols led by the hospital transfusion committee, tailored to the capabilities of each hospital and in line with organizational policies. Should include detailed procedures for activation of treating providers and supply blood products by the transfusion service, along with defined quality indicators and review criteria for outcome and protocol appropriateness. The continuous review and update should be done of all the protocols. Streamline the delivery of the blood, which is very, very important. Baseline transfusion should be monitored, and damage control resuscitation, that is support of high plasma to PRBC and platelet to RBC. For example, packs include 4 units of PRBC, plasma and platelets should be kept. Recent trends include using whole blood to simplify administration and reduce additional fluid administration, although it's not universally available, and component therapy may still be preferred in some setting. So what are the contemporary guidelines? The empirical delivery and coagulation therapeutics recommend the delivery of empirical packs of balanced resuscitation augmented with additional coagulation therapeutics based on the viscoelastic or conventional coagulation tests. These include fibrinogen concentrates, crab precipitate, platelet concentrates, procoagulant concentrates, and tranexamic acid. A continuous reassessment should be done. The strategy allows for ongoing evaluation of the dilutional resuscitation-induced coagulopathy and the treatment of established coagulation disorder. Tailoring treatment based on the pathophysiology like trauma, PPH, CLD is crucial. Prothrombin complex concentrate, PCCs, especially the 4-factor PCC, have been considered in various protocols primarily for vitamin K and antagonist reversal, and to a lesser extent for off-label to supply vitamin K dependent coagulation factor in various clinical scenarios. Now, concerns with PCCs: while the retrospective studies suggested potential benefit, the prospective study, that is the ProCoag trial, demonstrated that empirical PCC administration in trauma patients did not reduce the total blood product consumption and increase the thromboembolic events, highlighting an unfavorable risk-benefit profile. The Cryostat 2 trial investigated early empirical high-dose crab precipitate administration within 3 hours of injury, but found no improvement in 28-day all-cause mortality, questioning the efficacy of empirical administration. Now, the outcome of these 2 trials discouraged the empirical administration of coagulation factors concentrate without clear diagnostic support and emphasized the importance of the targeted therapy based on specific diagnostic findings. So finally, once the patient has received all the transfusions and everything, how to manage the bleeding and this massive transfusion in the ICU? The first thing that we must consider is the systemic and the physiological changes that the patient has undergone. The massive transfusion and the hemorrhage control lead to widespread immune system activation, potentially resulting in a dysregulated inflammatory state, that is immune suppression and sepsis. The patients may exhibit hyperdynamic state characterized by high cardiac output and vasodilatation, possibly obscuring ongoing hypovolemia. Myocardial ischemia during profound hemorrhagic shock can cause cardiac dysfunction, which is challenging to distinguish from other shock states. Initial coagulopathy may be followed by compensatory hemostatic activation and a thrombotic state exacerbated by delays or excessive administration of procoagulants or antithrombolytics. Now, continued volume resuscitation should be done. Capillary leakage from the vasodilatation and increased endothelial permeability may necessitate ongoing volume resuscitation post-massive transfusion. Liberal use is associated with increased mortality, that is increased use of the crystalloids due to increased endothelial permeability, and should be used judiciously. RBC transfusions are indicated for low hemoglobin levels to improve the oxygen carrying capacity. Regarding plasma versus crystalloids, plasma may help restore the glycocalyx thickness and support its integrity, offering a potential benefit over crystalloid in trauma patients. The next is the use of vasopressors and ionotropes. Early administration may help maintain perfusion level in patient with distributive shock due to SIRS, although it may mask hypovolemia. Secondary myocardial injury from ischemia and inflammation may necessitate inotropic support to manage cardiac dysfunction. Early management of hyperkalemia and hypocalcemia is crucial to prevent compounding cardiac dysfunction. So if you are giving early vasopressors, please also simultaneously check the volume status and continue giving the volume as well. Regarding thromboprophylaxis, a rebound hypercoagulable state is seen. Studies indicate a transition to hypercoagulable state within 48 hours after trauma, with evidence suggesting that could occur as early as 3 to 6 hours post-injury. Now, the VTE risk is up to 20% for trauma patients, and VTE is experienced in those patients with the risk of persisting despite pharmacological thromboprophylaxis. Challenges in traumatic brain injury is delay or avoidance due to concerns about worsening bleed in the brain, while paradoxical increased risk of VTE. Now, evidence for early thromboprophylaxis, early initiation may be linked with the need for repeated surgical intervention, although it effectively reduces the VTE risk. Guidelines, and in this, the Western Trauma Association algorithm provides guidance on determining the need for pharmacological prophylaxis, including type and dosing. The impact of VT thromboprophylaxis on bleeding progression is debated, with minimal evidence of associated outside CNS. Delays or missed dose of VTE prophylaxis can lead to increased morbidity. Now, pharmacological prophylaxis. LMWH versus unfractionated. Strong evidence supports the use of low molecular weight heparin over unfractionated heparin for trauma patients. Intermediate or high dose may be required due to low molecular weight resistance related to antithrombin 3 deficiency. Mechanical thromboprophylaxis. Data on mechanical thromboprophylaxis are mixed, but European guidelines recommend it for patients with contraindication to pharmacological anticoagulation and suggest a preference for intermittent pneumatic compression over graduated compression stocking. Do not support the preference of combining therapy over pharmacology or compression therapy alone. That is the American guidelines. Regarding the management of anemia, the prevalence is around 70 to 80% of the post-ICU patient, which is nearly half remaining anemic 6 months later also. Persistent anemia can hinder the patient's ability to engage in rehabilitation and recovery. The causes are anemia observed in critical ill is due to multiple factors, including the low erythropoietin level, iatrogenic blood loss, and functional iron deficiency. High hepcidin levels contribute to the functional iron deficiency, a significant mediator of anemia in this patient group. Now, massive transfusion and subsequent blood loss exacerbate the anemia, leading to significant iron depletion. Management, the erythropoietin and iron supplementation, proactive management should be done with these two agents and has been proposed to address the ICU related anemia. European guidelines advise against the use of EPO and iron in ICU patients due to the potential risks. EPO may increase the thrombosis risk in procoagulant state, while iron supplementation could be ineffective or harmful amidst systemic inflammation. There are some additional consideration which we must keep in mind, that is, individualized treatment algorithms should be made. Unique patient endotypes have been identified. Recent studies emphasize that massive hemorrhage management should consider unique patient responses, suggesting variability in how patients respond to resuscitation and treatment protocols. MHPs validated through RCT may not capture all patient variability, underlying the importance of tailoring treatment algorithm to individual patient needs. The other is resuscitative endovascular balloon occlusion of the aorta. Now, a pragmatic Bayesian RCT by Jensen evaluated this strategy of mortality in trauma patients with insanguinating hemorrhage, and the study indicated that the resuscitative endovascular balloon occlusion of the aorta combined with standard care did not reduce or may even increase the mortality. The other thing is search for an ideal anticoagulation. Mitigating the therapeutic anticoagulation risk, the quest for an anticoagulant that prevents thrombotic events without increasing bleeding risk is still ongoing. Targeting non-essential coagulation factors such as 11 and 12 might offer antithrombotic effects without elevating bleeding risks. Now, innovations include antisense oligonucleotides, antibodies, and other small molecules to inhibit the function of factor 11. Clinical trials with this, while targeting factor 11 shows promise, it requires careful balancing to avoid increased risk of minor bleeding, particularly in mucosal area in post-trauma or surgery setup. Ongoing phase 2 and 3 trials are evaluating the efficacy of contact pathway inhibition in various clinical settings. The next is a summary of all that we have known till now. So once a patient of that, like a bleeding patient, comes to the ICU or develops massive bleeding in the ICU, try to find the risks or signs of bleeding. That is tachycardia, tachypnea, narrow pulse pressure, and sudden increase in the lactate or base excess. So you keep monitoring the trend. If you see an increasing heart rate or increased lactate without any obvious shock or base excess going up, then you must think that there is a sign of internal bleeding. So perform lab tests, that is the basic lab test, look for the platelet levels, PT, APTT, and hemoglobin levels. Once you find any abnormality, you can go for the point of care analysis, that is TEG or ROTEM. Consider to implement both of these and see how they are getting interpreted. Determine the need for a massive hemorrhagic protocol based on the clinical signs and hemorrhagic indicators. Initiate standardized empirical packs for resuscitation. If it is a massive bleeding, the RBC, platelet, and plasma should be given together. Adjust the treatment algorithm based on the unique patient responses and underlying cause, that is trauma, PPH, CLD. Based on that, make a unique protocol for each group of patient. Augment with coagulation therapeutics, that is fibrinogen concentrates, poor coagulant concentrates, and tranexamic acid. Continuously reassess for dilution and coagulopathy and established coagulation disorders. Tailor the treatment to the patient's endotype and type of resuscitation. Monitor for systemic inflammatory response and hyperdynamic state and the cardiac function. Address the anemia. Consider giving RBCs or EPO or iron. Consider thromboprophylaxis. Initiate prophylaxis as early as possible. Consider LMWH over unfractionated, and a role of mechanical thromboprophylaxis in cases where I am unable to start the chemical treatment. Assess for appropriate resuscitation of endovascular balloon occlusion if there is an ensanguinous hemorrhage, and finally review everything and see how the patient is responding. Thank you for your patience.